This week we'll be discussing the treatment of unipolar depression. To start, we're looking at whether depression is a biological or an environmental depression. So depression is the most commonly presented issue in a mental health setting, so that will be the diagnosis you will see the most often working in the field. 17% of people will have at least one episode of depression in their lifetime, but only 30% of those will actually seek treatment for it. While treating depression, you must look at whether it's endogenous, so it's within the person, so if they have a biological predisposition to depression, or if it's exogenous, meaning it's being caused by something that's happening outside of the person in their environment. So it could be related to stress, could be related to grief, but both internal and external factors play a role in depression, so it could be a combination of things. But also when you're looking at causes of depression, you must also look at substance use, psychotic features, physical disease, and any medications that may cause depression. So there is a significant list of disorders and disease that can cause or make depression worse. It's on page 27 in your textbook about the basic psychopharmacology, page 27. So some examples are cancer, chronic fatigue syndrome, chronic pain, diabetes, malnutrition, postpartum hormone changes, and stroke. There's also a significant list of medications and substances that can cause or worsen depression, and that's on page 28. So that's everything from alcohol, anti-anxiety medications, anti-Parkinsonianism medications, cold remedies, corticosteroids, hormones, any other drugs of abuse, and sedative hypnotics. If there's no physical cause of depression, the treatment plan will be developed. So if there's nothing else that's causing depression, we need to look at what we could do to treat it. So looking at psychotherapy is an effective treatment, but also psychotherapy and medication is more effective, so the combination of. So if it's more of a dysthymia, it's more of a chronic mild depression, so somebody has a low-grade mood for a long period of time. Psychotherapy should be tried first as opposed to medication. If it's more of a grief reaction with a sleep disturbance, the medication can help to improve sleep, should be tried. But again, when we're talking about depression, we should always be assessing for suicidal ideation, because up to 80% of people struggling with depression have had some suicidal thinking at some point. So we're looking at treatment of biological depression. So there are many different types of treatments, so possible treatments for moderate to severe types of depression. We're going to go into each of them individually, but there is a link here to the Mayo Clinic, which is an American website, but it gives a lot of information about diagnosis and treatments of depression. So first off, counseling and psychotherapy. So generally those receiving psychotherapy see the greatest gains in treatment within the first 16 to 20 sessions. So if you're doing one a week, that's about 20 weeks. There are many types of therapies that are effective. Solution-focused therapy and briefer forms offer quicker solutions, while CBT approaches work better than other forms. So it's longer term, more manualized, skill-based. There are many types of medications for depression, but they are divided into 4 categories, which we'll look at individually. So the tricyclic antidepressants, these are the oldest types of antidepressants. They impact the reuptake of neurotransmitters. Excuse me. They do affect many other systems and organs in the body, and can cause a lot of side effects. So like sedation, weight gain, difficulty urinating, dizzy, dry mouth, sexual dysfunction, orthostatic hypotension, which is when your blood pressure drops quickly when you go from either sitting or laying down to standing. You can feel really dizzy, lightheaded, and possibly faint. Blurred vision is another possible side effect. They do pose a suicide risk due to the overdose potential. So somebody who's on a tricyclic, taking too many could actually cause an overdose, and a toxic reaction to the cardiovascular system. So some of these older antidepressants, clomipramine, amitriptyline, imipramine, trazodone is an older one. It has fewer side effects and less suicide risk. but it's used generally for sleep. So it's help people fall asleep at night. SSRIs, this is the one you probably hear the most about. This is the selective serotonin reuptake inhibitor. So it blocks serotonin from returning to the presynaptic cell, so that way there's more serotonin available in the brain. They have less side effects than the tricyclics, but some common side effects: nausea, headache, diarrhea, dry mouth, anorexia, meaning not wanting to eat, but also weight gain, restlessness, insomnia, tremor, sweating, yawning, dizzy, inhibited sexual desire, and inhibited orgasm. And it can interact with few other medications the patient may be taking. So it is safer. It is a safer medication who are at risk of suicide, meaning there's less overdose potential in this medication. But you still need to monitor for suicidal ideation always while especially when on medication. But the benefits of treating the depression outweigh the risks. Must also look out for serotonin syndrome, which is when serotonin becomes too high in the central nervous system. So things to look out for: agitation, confusion, insomnia, flushing, fever, shivering, muscle rigidity, hyperflexica, incoordination, diarrhea, and hypotension. This can be life-threatening, and you need to monitor closely, especially when starting the medication. And there's a link here regarding SSRIs and some more information around those. Heterocyclic antidepressants. So they have similar side effects to SSRIs, but fewer sexual dysfunction symptoms. Some examples: Effexor, Cymbalta, Remeron, Wellbutrin. So Remeron, or mirtazapine, which is its generic name, it's helpful in restoring normal sleep patterns, increase in appetite, but need to watch out for liver failure issues. Wellbutrin, it can be uplifting but agitating for some, so it's more of a stimulating type of antidepressant. Excuse me. It lowers the seizure threshold for those who are prone to seizures. So you have to be careful. If somebody who is already prone to seizures, they might have more seizures. Reduces appetite, so shouldn't be diagnosed with somebody who already has an eating disorder. MAOIs, things like Marplan, Nardil, Parnate. So it inhibits the MAO, or the enzyme that breaks down the neurotransmitters and renders them ineffective. Similar side effects to tricyclics, but you have to have very strict dietary restrictions. There are certain foods you can't eat, specifically ones with tyramine in them, and there is a link here regarding MAOIs and what you can and can't eat. Lithium is also a treatment for depression and bipolar, but we'll look at those in week 6, more specifically around bipolar disorder. So here's some specific information around depression in the elderly and depression in either mothers who are pregnant or are just postpartum. So I'd like to take some time to look at this information. It's specific to these two populations, and this information isn't covered in the textbook. So there are other ways of treating depression using more herbal or holistic substances, and you'll hear a lot of people taking these types of herbs. So specifically, St. John's wort. It's a plant that's said to control mild to moderate depression with not the side effects of antidepressants, but most clinicians do not believe that it helps treat depression. So there's some controversy around it. Got to be careful taking specific medications with St. John's wort. So warfarin, which is the blood thinner, and digoxin, which is a heart medication, and some HIV and AIDS medications. So there's some significantly adverse reactions when mixing St. John's wort with those meds. It should also should be taken in a liquid dose to assure the appropriate dose. And it should not be taken with other antidepressants, or it may cause the serotonin syndrome that was discussed earlier. Ginkgo biloba, this is a tree of Chinese origin, is said to relieve mild depression and increase memory and concentration. It's been used in Alzheimer's patients. It does have blood thinning properties, so you need to be very careful if you're already taking blood thinning medications. It's not as effective as antidepressants in the treatment of moderate to severe depression, so the worse the depression is, the less it will help. DHEA, so normally it's secreted in the adrenal glands, and it's a precursor to testosterone and estrogen, so it's already something that's in our bodies naturally. In adolescents have high levels of this, but the levels decrease with age. So when it's taken orally, it can reduce mild to moderate depression, but it can cause weight loss, increase large muscle mass, and may increase sexual appetite. But these claims have not been proven. But it may increase the risk for certain types of cancers. And some of the side effects: oily skin, acne, irritability, and potentially psychosis. SAMe, this is endogenous in our body as well. The body converts it into an amino acid which accumulates and can cause depression, joint problems, and cancer. So homocysteine can be converted back into SAMe by using vitamins B6, B12, and folic acid. So some research has shown that SAMe is effective in relieving depression, joint pain, and cleansing the liver of other toxins. And it may increase the synthesis of serotonin and dopamine and aid in communication between cells. Light therapy is another option as well for depression, specifically seasonal affective disorder. So those who become more depressed during winter months when there's less sunlight. Antidepressants can be helpful for SAD, but so are the use of light boxes. So there's specific lights that are used to treat seasonal affective disorder. So might suggest trying a light box first. Unless depression worsens, the person becomes suicidal, then we might have to look at medication instead. So looking at sitting in front of a full spectrum light for about 60 minutes per day. There is a video here from the CBC regarding light therapy for SAD. Importance of exercise: always encouraging people who are struggling with depression to exercise. It releases endorphins and associated with increased levels of endorphins and improvement in motivation, energy, and mood. And here's a link regarding mental health and motivation and activity from the Canadian Psychology Association. ECT. This is for patients who have severe depression and do not respond to antidepressants. So you've tried everything else. This is kind of the last resort. Excuse me. ECT is given to a person, is anesthetized and paralyzed. So electrodes are placed on the scalp. Electricity is administered, resulting in a seizure. So it's causing the person to have a seizure. But there's no movement because the person is immobilized, so they're not seizing actively on the table. They receive about 3 sessions per week for up to 4 weeks, or until there's improvement noted. Excessive ECT, though, can cause brain damage and memory loss, so you need to be careful. Some clinicians believe that the risks associated with ECT are equivalent or even preferable to many medications used to treat depression. New research into transcranial magnetic stimulation to the prefrontal cortex, which is the front of the brain, stimulation of the vagus nerve and other areas of the brain through deep brain stimulation offer relief to depression. There's a link here to CAMH and its information on ECT. So I'm going to pause here and we'll finish the last few slides in the second half.